Dr. Fabián Ocampo-Acosta. Hello, and
Hello.
he is going to present on the topic Myofibroblast in odontogenic cysts and tumors and the stromal interaction and its role in aggressive behavior of these entities. Yes, let's start with your presentation. Dr. Fabián, you can share your screen. All our participants are eagerly waiting to have a glimpse of your
Really?
presentation.
Okay.
Yes.
Thank you. Thank you. Well, good morning, everyone. Here in Mexico is still 10 a.m.
Okay.
Okay. This is the presentation. Okay.
Yes, you can go ahead, Dr.
Okay.
Fabián. You are
Okay.
audible and visible. Your screen is sharing. Yes.
Okay. Thank you. Let me close this. Okay. I am Fabián Ocampo-Acosta, oral pathologist. I'm working in dentistry school in the Universidad Autónoma de Baja California, Tijuana, Mexico. My co-worker is Dr. Jorge Paredes Vieira, and we are going to speak about myofibroblast in odontogenic cysts and tumors with that's its stromal interaction and its role in aggressive behavior of these entities. Thanks to the organizing committee for letting me share this study with all of you. Okay. As a background, odontogenic cysts and tumors share the same tissue sources, the odontogenic remnants, although they differ in their biological behavior and degree of aggressiveness. They appear exclusively in jaw bones or in the oral mucosa when they are peripheral. And the most recent World Health Organization head and neck tumor classification was released in 2017, in which are a chapter of odontogenic and maxillofacial bone tumors. Okay, in general, this schematic view approaches to how these lesions are classified. In the top of this schematic view, we had the odontogenic tumors, and this could be either malignant or benign. The benign are classified according to the predominant component that can be epithelial, mixed epithelial mesenchymal, or only mesenchymal. In the bottom, we look for the odontogenic cyst. There are other maxillofacial cysts, sorry. But in this case, they are of odontogenic origin and it could be inflammatory, like the most predominant inflammatory cyst, like the radicular cyst, or the inflammatory collateral cyst. And could be also developmental. The most prevalent developmental cysts are dentigerous cysts. Also, odontogenic keratocysts and orthokeratinized odontogenic cysts, among others. But we have to highlight this specific odontogenic tumor because of its aggressiveness, because of its frequency. We're going to highlight amyloblastoma, either conventional, solid, or unicystic, and these three odontogenic tumors for the same reason. As we can see, this is also my background image. They took almost the same in the initial stages. It could be anyone, so differentials has to be made along with clinical pathological correlations. with time, can achieve this appearance and classical fashion of bone destruction, teeth displacement, cortical expansion, etc. Like these ones. These are clear examples of those odontogenic cysts. Histologically, they are without a doubt of odontogenic origin, but we can use some immunohistochemical markers in case of hesitation, like in this one of odontogenic keratocysts. cysts. Similar characteristics can be observed in lesser aggressive entities, such as this orthokeratinized odontogenic cyst. But with time, we can it can cause a major bone defects. In this case of odontogenic tumors, the epithelial component can cause to have huge sizes, and the conventional treatment of that is large bone resections, like in this example of conventional amyloblastoma. So these qualities are attributed to various characteristics that the epithelial component acquires during the development of the lesion. There are a few studies on the non-epithelial component that could contribute to diverse biological behavior of different odontogenic cysts and tumors. Well, the myofibroblasts were first described by Gabbiani. Green cells, they can take part in the development of repair and normal tissue, as well as in various diseases processes, such as inflammatory bowel diseases, asthma, filaments contained in its cytoskeleton are defined by morphological and immunological criteria, being fundamental aspects of its phenotype. The simplest definition of myofibroblast is a smooth muscle cell-like cell, primarily by expressing alpha-smooth muscle actin in its cytoskeleton. However, it is suggested that myofibroblasts represent a state of differentiation of the fibroblast itself. A number of cytokines included platelet-derived growth factor, interleukin-4, insulin-like growth factor, and transforming growth factor beta could be involved in differentiation from fibroblast to myofibroblast. This schematic view of differentiation of myofibroblasts from stromal cells, mainly fibroblasts, shows focal adhesion mediating by integrins, by mechanical tension, having the cytoplasmic actin become a smooth muscle actin, and in the outer side, fibronexus attach fibronectin, and could be the transforming growth factor beta, the main growth factor that by these cells get this new phenotype and becoming myofibroblast. We don't know for sure if they can regress to a fibroblast. What are the functions? Well, in normal physiological conditions, we can have scarring, synthesis, remodeling, and repair of the extracellular matrix in non-scarred tissues, can produce various molecules of the extracellular matrix, such as collagen, elastic fibers, glycosaminoglycans, tenascin, and fibronectin, among others, both at the interstitial level and in the epithelial and endothelial basement membranes. The accumulation of fibroblast-like cells, including myofibroblasts, are frequently seen in association with the edge of an actively expanding tumor mass. Lewis demonstrated that stromal cells in squamous cells carcinomas in vivo express SMA, indicating a myofibroblastic phenotype. Myofibroblasts upregulate the secretion of large number of growth factors, chemokines, and cytokines, as well as extracellular matrix proteins and proteases. Many types of odontogenic lesions, particularly odontogenic keratocysts and solid ameloblastomas, although classified as benign, they locally demonstrate aggressive behavior and potentially lethal nature. Beret evaluated odontogenic cysts and tumors, and the stroma of these lesions harbored myofibroblasts as reflected by the SMA positive cells. Kosoltani studied the relationship between the presence of myofibroblasts in the capsular stroma of different cysts and odontogenic tumors, finding, for example, 86% positivity for odontogenic keratocysts, 53% in the integer cyst, 80% in unicystic ameloblastomas, 93% in solid ameloblastomas, and so on. On the contrary, Smith analyzed the presence of myofibroblasts with SMA in solid and unicystic ameloblastomas, concluded that although there were strong immunoreactions, the irregular distribution and the decrease of them in the stroma of solid ameloblastoma demonstrate that by themselves, myofibroblasts do not have an important role in aggressive behavior of the neoplasm. I believe the contrary. Anigoda found significant differences when comparing the presence of myofibroblasts with SMA between ameloblastomas and integer cysts, and between odontogenic keratocysts and integer cysts, without finding significant differences between ameloblastomas and odontogenic keratocysts, partially corroborating the action of myofibroblasts in the aggressive behavior of these entities. Well, the aim of this study was to correlate the presence of myofibroblasts with the aggressiveness of certain cysts and tumors of odontogenic origin. Well, the materials and methods was we took selected odontogenic cysts, 11 dentigerous cysts, 16 odontogenic keratocysts, 2 orthokeratinized odontogenic cysts, and 5 unicystic ameloblastomas and 5 conventional ameloblastomas. They were all prepared for conventional process for immunohistochemistry for immunoreaction to SMA. According to the positive control in each slide, which was cecal appendix, the immunoreactions and the intensity were determined. Well, which was the results? Okay. In this picture, we looked at the stromal aspect in the cyst and in the solid area of ameloblastoma for reaction using positive controls, like in the left upper side is the cecal appendix. And we compared, for example, in the dentigerous cysts or all the cysts of odontogenic origin, looking for this reaction in capsule or in the solid areas of ameloblastoma. Surprisingly, the integer cysts had mild and moderate intensity in all cases. Odontogenic orthokeratinized cyst was lesser, although one of them was, had an intense reaction. Ameloblastomas, cystic and solid, behavior similarly between them, and odontogenic keratocyst shows the most intense reaction to it. Here are the percentages of the frequency of this immunoreaction, being the odontogenic keratocyst, which was showed the most intense and constant immunoreaction along the study. And the mean and the standard deviation shows that only the odontogenic keratocyst has a p-value which is statistically significant. Well, these results showed that there was no significant difference according to the diagnosis, only in odontogenic keratocysts. In contrast with those of results of Barrett, in which, according to the diagnosis, there was a different immunoreaction, being less in odontogenic lesions that do not show an aggressive behavior, such as the dentition cyst, orthokeratinized odontogenic cyst, and ameloblastic fibroma. And much higher in odontogenic keratocyst, cystic, solid ameloblastomas, even when with immunoreaction similar to the invasion front of intraoral squamous cell carcinomas. On the other hand, Ramos in 2014, when conducting a similar study, increasing the immunohistochemical test for Ki-67, MMP-129, showed that there was also no significant difference in immunoreaction with the SMA in odontogenic keratocysts associated or not with Gorlin syndrome when compared to dental follicles. It is proposed that the epithelial transformation of odontogenic cysts and tumors can generate recruitment to generate a favorable microenvironment in the successful development of these lesions, regardless of the biological behavior of each one of them. What could be concluded in this study? Well, that there are diverse and multiple evidence regarding the presence of myofibroblast in the capsule or in the front of invasion of these entities, with most of it pointing towards the partial interference in the aggressiveness of such lesions. And we can identify therapies aimed at reducing dimensions or even curing aggressive odontogenic neoplasms in the use of mutilating surgeries associated with late diagnosis and the aggressive nature of certain entities of odontogenic origin. Where we have to move forward? Well, not only looking for SMA in the capsule or in the stroma of these kind of tumors, but also look for WNT pathway, beta-catenin, making a correlation with transforming growth factor beta and also STAT3. We can look also for some kind of software for scoring immune expression more accurately, and always looking for genomics, epigenomics or proteomics of these entities, which are running right now. Here are some references, and I want to thank some of my friends, some people like Douglas Knepp, like Lester Thompson, like Dr. Beatriz Aldape, which are people who inspire me to be more, to be like them, to be better. And I want to thank my family. I think my daughter and son are looking at the conference. Hola, Fátima.